Okay, so here we go with part 2 on goniometry. These are the lecture questions for this week's quiz. I answer these through this PowerPoint. Plus minus manual muscle testing. There is no plus minus manual muscle testing on the first practicum. I'm going to repeat that. There is no plus minus manual muscle testing on the first practicum. It's all just that 0 through 5 scale. We start to play around with it a little bit in the second practicum and the third practicum, and I think there might be some of it on the midterm exam as well. And there's a lot of different parts to plus minus. The only parts you need to know for the midterm and the latter practicums are what's in red. 2 minus, 2 plus, 3 minus. These are kind of like for those measures that are in between. So 2 minus, which is called poor minus. Patient initiates but can't perform full range of motion with gravity minimized. So think of shoulder flexion. They can't do it against gravity. Put them side lying, and they can't go all the way up and side lying. If they could go all the way up and side lying, that would be a 2. They go like halfway, it's a 2 minus. 2 plus. Patient performs full range of motion with gravity minimized with slight resistance or less than half of full motion against gravity. 3 minus. Patient performs greater than half of range of motion against gravity. Again, this is hard to kind of just verbalize through it. But again, if you think of shoulder flexion, standing against gravity, if they go less than halfway, it's 2 plus. Greater than halfway, but not all the way, it's 3 minus. Everything else is pretty much the same. This 3 plus, 4 minus, 4 plus. It's kind of here as an FYI reference. Maybe some questions about this potentially in the board exam. But in terms of this class, just need to know the 0 through 5 scale, and then these ones in red for the latter practicums in the midterm. Okay, this idea of range of motion, what is it? Why do we need to measure it? All that sort of stuff. It's very much a biomechanical view of the body. When you get into theory and stuff with Chris's class, we'll tackle the biomechanical theory. Range of motion is very much looking at the body as a series of parts, almost like a machine kind of thing. How much motion do you have in a joint? Is it full motion, impaired, whatever? Potential full motion of a joint. Why do we care about it? Full range of motion. Obviously, you have more function. You can do things if you get full range of motion of your joint. And maintaining that range of motion helps prevent deformity, contractures, adhesions, that sort of stiffness, that sort of stuff. Just some kind of funky examples of this. Let's kind of visualize this little squirrel here. So you're looking through the eyes of a squirrel, life as a squirrel. So he wants to get at that ice cream that he sees in front of him. You can just see his eyes are bugging out. He very, very much wants the ice cream. But his both arms actually, he has impaired range of motion, let's say in his shoulder joints, and here it looks like his elbow joint is impaired. So he can't reach out and get the ice cream. He has impaired range of motion. It's impairing his ability to do what he wants to be able to do, which is get at that pistachio, is it? Chocolate mint ice cream. Down here, bottom right, this squirrel has amazing range of motion in his trunk, in his shoulders, elbows. He gets the food. So intact range of motion. He said some therapy from a team of expert occupational therapists who specialize in squirrel rehab, and he now has great range of motion, so he can functionally do what he wants to do, which is to get the food. What causes limited range of motion? All kinds of different things. Trauma, some kind of injury to the joint. Neurological insult. You'll learn more about these as you kind of go through the program. A stroke, spinal cord injury. They may be partially paralyzed, so they obviously cannot lift and move their arms or legs like they used to. Contractures, that kind of goes through degrees of contracture are stiff and it gets stuck and then it just becomes a permanent kind of thing. Just think of it as, at this point, just think of it as stiffness in a particular joint. Scar tissue, somebody had an injury, classically a burn, they've had a burn injury. The joint, the tissue gets constricted, it tightens up, binds up. As a therapist, sometimes you're trying to work through those adhesions to work through that scar tissue to get their motion back. Talked about burns. Spasticity goes with neurological insult. We talked a little about this. The input from the brain down to the joint and the muscles is off, so we have excessive muscle tone. Can't move a joint, or it makes it too tight, I guess you could say. Joint fusion. Sometimes they purposely fuse a joint to decrease pain, that sort of thing. Very commonly in the back, they fuse cervical vertebrae, that sort of thing. Obviously, that's going to limit your range of motion. Different kinds of arthritis. RA is rheumatoid arthritis. OA is osteoarthritis, which is very common. Arthritis, as you probably know, causes inflammation, swelling in the joint, deterioration of the joint cartilage, and you lose range of motion in your joint. There are other ones. These are just some of the causes. Why should we measure it? Again, like the muscle testing, it shows a progression to yourself, to the insurance, to the client, and it has a degree of scientific reliability. Everybody does it kind of the same way. How do you measure? You measure all kinds of different ways. We're going to be measuring a lot with the goniometer. This is a goniometer right here, kind of like a protractor. The axis goes right over the joint, and you're measuring how much that joint moves. Does it go all the way out fully, or is it constricted in some way? You can also measure joint motion just by observing. If somebody's lifting their arm, can they lift it all the way up? You can just tell, kind of anecdotally, they don't have full range of motion in their shoulder. You can use measuring tape. They're using measuring tape here to measure how much spinal flexion she has, the spinal process. You can measure the muscle length. That's just kind of beyond this class. And you always want to compare to the good side. I think this is one of the lecture questions, to see what is normal for that particular person. Everybody has a different normal and slight variations, and you'll see that in the lab when you're working with a partner. She may have different degrees of motion than you do. She may be extra flexible, less flexible. So you compare to their good side. So let's say her right shoulder is impaired. You check out the motion of her right shoulder, and you check it to the good side, because this is your normal, if this side was unaffected. So when you're thinking of goals for this side in terms of range of motion numbers, say you want to get back to 180 degree shoulder flexion, because that's what she shows on her good side. Losing the mouse here. You always want to compare to the good side. How do we address range of motion deficits? A lot of different ways. We compensate, we remediate again. Examples of remediation: stretching. Modalities. You may, for example, when we say modalities, we're talking about heat and ice, classically, ultrasound, lots of variations of modalities. Heat and ice is the most primary one. So, for example, if you heated up the joint with a hot pack and then you stretched it, that all would be remedial. And activity. For Helena in the store, she was washing the floor, scrubbing the floor with her new improved shoulder. She was working on the strength and the range of motion of her shoulder, remediating it through an activity. An adaptive device, you're compensating. Somebody cannot reach their arms up to their high enough to brush their hair. You would compensate as an OT by giving them a long-handled brush. A brush with a long handle and an angle on it, and will help them brush their hair without full range of motion. So not really trying to improve the range of motion. You're just helping them compensate so they can brush their hair. Splint, this one's a little bit confusing. It can be both remedial or compensatory. You can use it to compensate for a lack of motion, or it can help regain the motion back. Contraindications for goniometry, very similar to manual muscle testing. If there's some kind of infection and inflammation in the joint, you may not. These aren't like cut and dried all case scenarios. It really depends on the situation, but in a lot of situations, if they have inflammation in their joint, especially say like a rheumatoid arthritis and it's flared up, you don't want to be ranging it, stretching it, because you could damage their joints. Osteoporosis, you probably would not want to be working on a lot of spinal range of motion without some of this osteoporosis. Hypermobility, excessive range of motion. Joint subluxation, which is like a separated shoulder. Hemophilia, if you know what that is, that's internal bleeding. You don't want to be messing with that. Same with a hematoma, which is like a blood clot within your body. Any kind of acute injury. Somebody just fractured their shoulder, you're not going to be grabbing that shoulder and just, arranging it out. Bony ankylosis, like the book talks about this, union of bones in a joint due to loss of articulate cartilage within the joint. The goniometer, again, this is some of the ones we use for the bigger joints, like the shoulder, uses for hip and stuff. Here's the axis. This usually goes right over the joint axis, and it's 0 to 180 for the joints, degrees of that. The shoulder is 0 to 180. Others are not so much all that way. One has a fixed end and one has a movable end. Something called floating goniometer syndrome, FGS. When you measure it, again, this is hard to kind of talk you through it. You're measuring it, putting it on the joint, and then you're taking it away from the joint and remeasuring it. Inconsistent landmarks. We'll talk about that again in the lab. Kind of a step-by-step. Start them in anatomical position. You demonstrate the motion. Watch them do it. Looking for that quality of the movement. Can they go all the way up? Are they compensating? Ask about pain. Compare to their good side. You could attempt passive range of motion, ideally, stopping with pain, and then you're doing the thing. See how she's got it, the axis right over the joint, the fixed end, the movable end. Starting here, this is their 0, or actually there's no 0 because the way she's doing it, so this is be like starting at 30 degrees, and then maybe elbow extension. If she goes all the way up, maybe 30 to 180. Again, you have to kind of see it and do it to get a sense of it. It's always 0 to whatever it is for the most case, or 180 to whatever it is. Goniap. We're going to be doing videos, more and more videos in this class because of the COVID stuff. So those of you who don't get the Goniap, choose not to get it. They're not going to be professional videos by any means, but we'll kind of walk you through that, giving you more videos on goniometry as we work our way into that.